everyone, myself Dr. Prashant, and today we are going to discuss this case that is post-traumatic elbow deformity in a child. So the case is about Cubitus Varus deformity. So what Cubitus Varus deformity is, to understand the fact, firstly we should know that in a normal individual, the elbow is in some amount of valgus. So if I draw an axis along the long axis of arm and another line along the long axis of forearm, the angle between the two is carrying angle of the forearm. So this normal carrying angle is in valgus for an individual. And what is the value of normal carrying angle? For males, this is 5 to 10 degree, and for females, it would be 10 to 15 degree. But if the angle is less than 5 degree, then it becomes cubitus varus. And if the value is more than 50 degree, it becomes cubitus valgus deformity. So in this lecture, we will be discussing cubitus varus deformity. So this picture shows that a line along the long axis of arm and a line along the long axis of forearm is giving us an angle of nearly 30 degree, but this is varus, not a normal valgus angle. So this is a child who presented to us with this deformity of cubitus varus. So we will be discussing a case in this presentation. So this deformity is looking similar to this gunstock. So we also call this deformity as gunstock deformity, with which the child presented to us. So now coming to the case, a 6-year-old child came to us with a deformed elbow who had history of trauma. So what next we should ask? We should ask always whether this is the only joint involved or multiple joints are involved, or does the child have dominant limb involved or the limb is not dominant. Why is it so important? Because this is always the dominant limb, which if affected will affect the child most functionally. And we should also ask whether the deformity is increasing with time or not, because progressive cubitus varus can be because of etiologies like non-union of medial condyle fracture, or this could be because of avian of trochlea, or this could be because of metabolic causes also. But a non-progressive one could be because of malunited supracondylar humerus fracture. So this is always very important to ask whether it is progressive or non-progressive cubitus varus deformity. Once we have taken the history completely, we should examine the deformity locally. So always follow the dictum of look, feel, move, measure, and then spatial tests. So firstly, we will be just looking at the child's deformity. So definitely a line along the long axis of arm and another along the long axis of forearm, giving us this deformity of cubitus varus. We should always compare it with opposite side. If opposite is in normal carrying angle, that is 5 to 10 for males and 10 to 15 for females, and the affected side is beyond this normal limit, whether it is cubitus varus or valgus, we should always quote it as a deformity. So this child was having normal carrying angle on the opposite side, and on the affected side he was having cubitus varus deformity. So on look, we first saw the deformity, what it is, whether it is cubitus varus or cubitus valgus. Now coming to the next slide, we made the child to make both the elbows in extension. So in this image, you can very clearly see that on the unaffected side, that is normal side, the elbow was going in normal extension. But on the affected side, you can see in the side-by-side image, the elbow is going in hyperextension. This is nearly 10 to 20 degree of hyperextension. That you can see very well in this comparative image. So after seeing this hyperextension deformity, this is another case in which the hyperextension of the right side is very well seen in this child as compared to the opposite one. Once we have seen the hyperextension of the child, we should always look for what we call three bony point relationship. And to see this three bony point relationship, we should keep both the elbows in a similar position. We can ask the child to put both the hands over the head so that both the elbows are visible to us. And before doing this, we should always mark the 3 points. that is olecranon, medial epicondyle and lateral epicondyle, so that we can make out and we can compare the two sides, whether all the three sides are comparable or not. So this is how we see three bony point relationship, and three bony point relationship is usually maintained in malunited supracondylar humerus fractures, and this is not maintained in elbow dislocation cases, lateral or medial condyle fractures, and sometimes in long-standing cases of supracondylar humerus fractures which are malunited. Now coming to the feel part, the first thing we should be doing is feel the three bony point relationship. We should be seeing whether the three bony point relationship is maintained or not. That is the most common thing we should be seeing during feel part. So for this child, three bony point was maintained. So what all findings we do have right now? The child had cubitus varus deformity, had hyperextension, and the child had maintained three bony point relationship. Coming to the next slide, what else we found during examination? So during the feel part, supracondylar ridges were thickened. Both the supracondylar ridges. Both supracondylar ridges are usually found thickened when the child have malunited supracondylar humerus fracture, when only lateral ridge is thickened for lateral condyle fractures, when they are malunited or non-united, and medial ridge is usually thickened when medial condyle fracture is either malunited or non-united. That you should keep in mind. Now coming to feeling for any bony mass around the elbow. Why is it important? Because whenever a child does have multiple exostosis around the joint, that could be found in multiple hereditary exostosis, that can also cause deformities of the joint, like cubitus varus or valgus, or it could be genu varum or valgum. So that is very important to examine. Coming to the move part, during movement we found that this side was having hyperextension of nearly 10 to 20 degree, but as soon as the child flexes his elbow, we can see the difference between the two sides, that this side is flexing less as compared to the normal side. This child was having hyperextension of left, that is affected side. Along with that, flexion is also less on this affected left side. But one thing you should always remember is that arc of motion is normal. Supposingly, if 15 degree flexion is less, then the child will have 15 degree of hyperextension. Okay, but the arc of motion is normal. That again is suggestive of a finding which is found in malunited supracondylar humerus fracture, because the fragment malunites in hyperextension. That is the deformity which is found in malunited supracondylar humerus fracture, and because of that malunion and hyperextension, child will have exaggerated hyperextension, and along with that reduction in flexion, that would be concomitant with the deformity of hyperextension. Okay, so coming to the concept of deformity versus attitude. What is the difference between deformity and attitude? In deformity, if a child is having deformity of flexion, then its opposite movement, that is extension, will not be possible. But in attitude, if a child have flexion attitude, then extension, that is opposite movement, will be possible. This is the difference between deformity and attitude that you should always keep in mind. During the movement part only, we came to measure about rotations around the shoulder also. So when we compared in external rotation of the affected side, this is the external rotation of affected side that was less as compared to external rotation on the normal side. So external rotation was found restricted, and when we came to measuring internal rotation, that was found to be exaggerated. This was affected side, and when we compared it with the unaffected side, normal side, this rotation was less. So internal rotation of affected side was more than internal rotation of normal side, and concomitantly external rotation of affected side was less than external rotation of normal side. This again is complying with the finding that arc of motion is normal. Again, a finding which is found in supracondylar humerus fracture, that is malunited. And when we measure this internal rotation in this lying down position, when the child is lying in prone position, we have given a name to this test, that is Yamamoto's test. In any way you can measure the rotation around the shoulder, but when you are doing this in prone lying down position, this is known as Yamamoto's test. Now coming to the measure part, always measure 3 bony point. All the 3 limbs should be measured and compare with the opposite side. That will tell you whether it is comparable or not. After that, you should always measure the angle of deformity. What is the angle of deformity? If this is a child having normal valgus angle on the normal side and having cubitus varus deformity on the opposite side, affected side, so you measure that this normal side had 10 degree of cubitus valgus, and he had nearly 10 degree of cubitus varus on affected side. So angle of deformity will be 10 plus 10. That would be he have deformity of 20 degree, because he should have normal 10 degree cubitus valgus. And if he is having 10 degree of cubitus varus, the deformity is 10 plus 10. So that you should know. Now coming to the neurovascular examination, you should always look for the involvement of median, ulnar or radial nerve, because we have already discussed that in supracondylar humerus fracture, any of the nerve could get involved depending upon whether it is posterior-medial or posterior-lateral displacement. Whenever the displacement is posterior-medial, radial nerve gets involved. Whenever the displacement is posterior-lateral, median nerve gets involved. And whenever the fracture is in flexion, not extension type, ulnar nerve can get involved. And whenever a child is having cubitus valgus because of non-union of lateral condyle, the child can have tardive ulnar nerve palsy. So always go for neurovascular examination in all these cases. So coming to the diagnosis part, what will be the diagnosis of this case? So this is a 9 or 6-year-old, whatever is the age of the child, a 9-year-old male child with cubitus varus deformity of left elbow, and that is the dominant limb, with angular deformity of that whatever you have measured, maybe 20 degree, 30 degree, which developed secondary to post-traumatic supracondylar distal humerus fracture, that is malunited, without distal neurovascular deficit. And the next question that will be asked to you is, why is it secondary to post-traumatic supracondylar malunited distal humerus fracture? So we should have some points which are in favor of our finding. So this is cubitus varus deformity first, that is non-progressive. That is the first finding which is in favor of our diagnosis. Second is this developed secondary to trauma. Secondary to trauma, so that caused supracondylar humerus fracture. That is also corresponding with our findings. If the child had thick supracondylar ridges and both the ridges were thickened, so that again is in correspondence to our findings. Thirdly, 3 bony point relationship was maintained. That is very important. In lateral condyle non-union, this will not be maintained. And the child had hyperextension, although the arc of motion was preserved. That is also very important. And one finding that was external rotation was restricted and increased internal rotation was present. That is Yamamoto test. That is also a finding in supracondylar humerus fracture. Why all these findings are developing? Because supracondylar humerus fracture, when it malunites, it has 6 displacements usually. One is medial tilt, with angulation. It can have posterior tilt or angulation. It does have impaction, that is shortening, and it does have internal rotation. Because of all these, because of posterior tilt, the child will have hyperextension. Because of this internal rotation, child will have Yamamoto test positive. And because of this medial tilt or angulation, child will have varus deformity. So this is how you should remember it. Because of what all displacements the child is developing all these deformities, okay? If the child doesn't have three bony point relationship maintained, then what you should always think. Firstly, it could be because of cubitus varus could be because of non-union of lateral condyle also. Lateral condyle fracture non-union can cause both valgus or varus deformity. Yes, valgus is commoner than varus, but child can have both the deformities. And supracondylar humerus fracture malunion can also cause both the deformities, varus and valgus. How? In posterior-medial type, that is commoner one, you have varus deformity, but in posterior-lateral displacement, you will have this cubitus valgus deformity that you should always remember. And even if the child have posterior-medial type of supracondylar humerus fracture malunion, he can have disturbed three bony point relationship. Why is it so? In long-standing cases, we can have pull of triceps over the olecranon, which can cause disturbed three bony point relationship. So all these points you should know. So what all are the DDs for disturbed three bony point relationship? Lateral condyle fracture non-union, progressive deformities will be present in these cases, and thick lateral supracondylar ridge will be found whenever the child is having lateral condyle fracture non-union. Not both the ridges will be thickened, and three bony point definitely will be disturbed, and a ballotable mass will be felt over the lateral condyle. That is nothing but non-united lateral condyle fragment, and the elbow will be stiff. Range of motion, the arc of motion which was found to be normal in this case will not be there in lateral condyle fracture non-union, and the child can have tardioulnar palsy because of why? Progressive cubitus valgus. As the deformity keeps on progressing, ulnar nerve keeps on stretching, and ultimately the child will have tardioulnar palsy. So these all are the findings which are found in lateral condyle fracture non-union. What if the disease is bilateral? If the child is having deformity of both the sides, what you should always think? These could be endocrine disorders like rickets. Child can have multiple epiphyseal dysplasias, and if child is having bony masses all around the joint, it could be multiple hereditary exostosis also. So coming to the management of cubitus varus, since this is mainly a cosmetic deformity, mainly a cosmetic problem, this is not a progressive disorder, and arc of motion is also normal. Child doesn't have much of the functional problems, so this condition can be left alone. You can convince them, you can always tell them about the nature of the disease. If the parents opt for conservative management, yes, very well, you can go for it. But in Indian setup, most of the time the child could be a female child, so the concerns regarding the marriage of the child and many social stigmas, they arise. So the parents might be thinking of getting it treated. So what should be done in that case? We have to do osteotomy. Corrective osteotomy needs to be done. What all corrective osteotomy do we have? We can go for wedge osteotomy, that is supracondylar wedge osteotomy. So if this is the affected part, and if this is going in varus, so if the joint is going in varus, this part would be formed more. So either you have to do lateral closing wedge, you have to take this wedge out and close it so that the varus gets corrected, or you have to do what? Medial open wedge. So the name of the osteotomies are lateral supracondylar closed wedge osteotomy or medial supracondylar open wedge osteotomy. Since the deformity is three-dimensional, and in this wedge osteotomy we are correcting only one dimension. So today we have come with newer osteotomies that correct this deformity in all three dimensions. That is nothing but dome osteotomy. So you should be knowing all these things about supracondylar humerus fracture malunion that leads to what we call Cubitus Varus Gunstock deformity. So I feel that you found it useful. Thank you.